Continuing with our first section, we will talk about CIDP or chronic inflammatory demyelinating polyneuropathy in this section. Let's give you an overview of immune-mediated neuropathies. Immune-mediated neuropathies are among the several causes of polyneuropathies, which are common clinical disorders caused by immune responses against autoantigens in the peripheral nervous system, characterized by progressive muscle weakness in both distal and proximal segments of the nerves. These neuropathies range from a fulminant, life-threatening crisis to an asymmetrical, minimally progressive process, often associated with autoantibodies against neuronal epitopes. The main pathophysiological mechanism of nerve injury in these neuropathies includes immune-mediated nerve demyelination, axonal damage, and vasculitic-induced nerve ischemia. These neuropathies include acute disorders such as GBS and its variants, and certain chronic disorders such as CIDP, multifocal motor neuropathy, and certain neuropathies associated with immunoglobulins, IgM, or it is known as MGUS, multifocal monoclonal gammopathy of undetermined significance. In this section, we are focusing only on CIDP and its variants, and other neuropathies will be dealt with later on. So, chronic inflammatory demyelinating polyneuropathy is a rare neurological disorder in which there is damage of peripheral nerves, and it specifically affects the fatty insulating covering of the axons known as the myelin sheath. This affects how the signals are transmitted across the axons, and it leads to loss of nerve fibers. Due to this loss of nerve fibers, there is weakness, paralysis, and impairment of motor function, along with the sensory dysfunction. And all these impairments are mostly symmetrical. In this section, we are going to talk about the clinical manifestations of CIDP. We will discuss that how many subtypes of CIDP are there, and what is the pathogenesis of this neuropathy, and finally how we can diagnose and treat this condition. So CIDP is basically an acquired immune-mediated inflammatory disorder of the peripheral nervous system. It is characterized by chronic, progressive, relapsing or monophasic symmetrical weakness in both proximal and distal muscles. There are sensory disturbances and paresthesias due to distal fiber sensory loss, and absent or diminished tendon reflexes, which usually progress over 2 months. It is sometimes thought of the chronic form of acute inflammatory demyelinating polyneuropathy, which is the most common form of GBS. This chronic course distinguishes CIDP from GBS. All the demyelinating polyneuropathies, they occur more commonly in males and usually from middle to old age. The incidence of CIDP is lower than GBS, but its prevalence is much greater. The overall prevalence of CIDP is around 6 cases per 100,000. Being the most common type, CIDP has an estimated prevalence rate of around 1 to 8.9 cases per 100,000. Whilst the process is quite similar to its acute relative called Guillain-Barré syndrome, or GBS for short, it shares many common features, some of which are elevated CSF protein levels and electrodiagnostic findings of acquired demyelination. There are a number of differentiating features between these two neuropathies. In most cases, patients with CIDP do not identify a preceding viral or infectious illness, so there is no obvious cause in case of CIDP. GBS is a subacute disorder that usually progresses over 3 to 4 weeks Then it plateaus and improves with time and does not recur. Whereas CIDP has symptoms which are ongoing for around 8 weeks and it does not improve unless ongoing treatment is given. CIDP has a slower onset and the rate of progression is far more insidious. Patients do not present for several weeks to doctor until the symptoms are much worse. The pattern of weakness in case of CIDP is patchy, asymmetrical, and multifocal, involving both the distal and proximal segments simultaneously, in contrast to the symmetrical ascending pattern of weakness in GBS. Now, these neuropathies, or talking about CIDP in particular, it exists in several subtypes which are identifiable on the nerve conduction studies. The most common type, which is the classical or the standard CIDP, it exists in around 50 to 60% of the cases. It occurs in two forms. One of them is the subacute form and an acute onset form. CIDP involves both the motor and sensory fibers, and it usually involves both the distal and proximal segments. Another common subtype is the MADSAM, also called as multifocal acquired demyelinating sensory and motor neuropathy. It occurs in around 20 to 30% of the cases. It is very asymmetrical and it usually involves the upper limbs only. Another rarer variant of CIDP is DATS, also called as distal acquired demyelinating and symmetrical neuropathy. This variant involves distal segments predominantly and sensory fibers more commonly than the motor fibers. And it usually occurs in only about 5% of the patients. Now, there are certain motor predominant and sensory predominant and focal expressions of CIDP, as much as rarer entities. The acute onset form of CIDP, it should be differentiated from GBS. And how it can be differentiated from GBS? It is only considered when the GBS starts deteriorating more than 9 weeks after the onset, or it relapses at least 3 times. And this is very important to differentiate these two subtypes. The onset of CIDP is gradual over a few months or longer than that. Initial attack is usually indistinguishable from that of GBS because there is no obvious cause in case of CIDP. Symptoms are both motor and sensory, depending specifically on which component of the peripheral nerve is involved. Weakness of the limbs is symmetric, but it is strikingly asymmetric in case of MADSAM neuropathy, also called as multifocal acquired demyelinating sensory and motor neuropathy. And in a variant of MADSAM, which is also known as Lewis-Sumner syndrome, in which there are discrete peripheral nerves involvement. Now, Lewis-Sumner syndrome is a rare disorder. It is characterized by asymmetric, multifocal weakness of arms and limbs with sensory dysfunction. And in a few cases, diminished tendon reflexes are also found in case of Lewis-Sumner syndrome, but its exact cause is unknown. Some of the patients present with a chronic progressive course, while others, usually younger patients, they have a relapsing and a remitting course of this disease. Some patients present with only motor findings, such as weakness or paralysis of certain part of the body, usually involving the arms or feet. A small proportion of patients present with relatively pure syndrome of sensory ataxia, indicating that only the sensory component of the nerves are involved in these types. In around 10% of the cases, patients present with tremors, which become more prominent during periods of subacute worsening or improvement. In a small proportion of patients, cranial nerve findings are also found, which include external ophthalmoplegia. Now, this is a schematic illustration of the basic principles of cellular and humoral immune responses. Although there is no evidence of any cause of CIDP and its variants, but there are certain evidence are present to support the hypothesis that these neuropathies, or specifically CIDP, is immunologically based and it has multiple triggers. Both the cellular and humoral immune-mediated responses are thought to be involved in the pathogenesis of CIDP. Now we will discuss the pathogenesis in detail. So this is a systemic immune compartment. As you can see here, the T cells recognize a specific autoantigen in the context of major histocompatibility complex class 2, and the co-stimulatory molecules on the surface of antigen-presenting cell, which is basically a macrophage. The macrophages act as antigen-presenting cells. They capture the antigen and present it to the T cell. An infection might trigger this event through molecular mimicry. A cross-reaction toward epitopes shared between microbial agents and nerve antigens. Now, what happens is these activated T lymphocytes, they can cross the nerve-blood barrier. This is the blood-nerve barrier or the nerve-blood barrier. These activated T cells, they can cross this barrier by in a process involving cellular adhesion molecules, such as intercellular adhesion molecules or vascular cell adhesion molecules, matrix metalloproteinases over here, and certain chemokines. All these intercellular adhesion molecules, these matrix metalloproteinases and chemokines, they damage the blood-nerve barrier and they allow the T cells to enter the peripheral nervous system. So this is the peripheral nervous system. Within the peripheral nervous system, T cells activate macrophages, and this activation of macrophages, it enhances the phagocytic activity, and it produces certain cytokines and inflammatory mediators such as the tumor necrosis factor alpha, reactive oxygen intermediates and nitric oxide, and certain complement proteases. All these chemokines and inflammatory mediators, they are responsible for causing the damage to the axons. Now, the autoantibodies, they can either cross the blood-nerve barrier or they are produced locally by plasma cells within the peripheral nervous system. These autoantibodies contribute to the demyelination and axonal damage. Autoantibodies can mediate demyelination by antibody-dependent cellular cytotoxicity, potentially blocking the epitopes. Epitopes are basically the area between which is present in the nodes of Ranvier. So these antibodies specifically attack these epitopes that are functionally relevant for nerve conduction, and they activate the complement system. They activate the complement system by a classic pathway, yielding pro-inflammatory mediators and the lytic membrane attack complex C5b and 9. All these membrane attack complexes and the activation of classic pathway, it leads to the damage of these axons within the peripheral nervous system. Now, how this process is terminated. Termination of inflammatory response, it occurs through the induction of T-cell apoptosis. Apoptosis is a process by which the body starts getting rid of the cells which are not required in the body. It is a natural cell death process that occurs from inside the cell. So the T-cell termination occurs through the induction of T-cell apoptosis and release of certain anti-inflammatory cytokines, including the interleukin 10 and the transforming growth factor beta. The myelin sheath, now if we see this closer structure of myelin, it is composed of various proteins such as myelin protein 0, myelin protein 2, and myelin basic protein. Now, this myelin protein 0, it accounts for around 50% of the total membrane protein in human peripheral nervous system myelin. Myelin is basically divided into two types, a compact myelin and a non-compact myelin. This myelin protein 0, the myelin protein 2, and myelin basic protein, these three are the part of compact myelin, whereas the myelin-associated glycoprotein, the connexin 32, and the ganglioside, these are part of the non-compact myelin. In case of CIDP, the immune response usually attacks the non-compact myelin segment of the peripheral nerves. These molecules have been identified as the target antigens for antibody responses with varying frequencies in patients with this disease. So this was all the pathogenesis of CIDP. Now, although there is evidence of immune activation in CIDP, the precise mechanism of pathogenesis is still unknown. If we biopsy a specific segment, it reveals a little inflammation and onion bulb changes, which is imbricated layer of Schwann cell processes around the axon that result from recurrent demyelination and remyelination. Whenever there is an immune process going on inside a peripheral nerve, the myelin sheath or the fatty protective covering of axon is being attacked. Macrophages are signaled to insert themselves within the axons, and they specifically target the myelin sheath, stripping it away from the axons underneath. When this occurs, and if we biopsy that particular damaged segment of axon, such as this segment over here, we can find onion skin appearance-like effect under the microscope. Now, the response to therapy of CIDP suggests that it is an immune-mediated process because it responds to glucocorticoids, whereas GBS does not respond to glucocorticoids. Now, there are certain hypotheses given for the pathogenesis of CIDP, which include the humoral autoimmune pathogenesis or the cellular autoimmune hypothesis of pathogenesis. These hypotheses are being supported by the evidence, such as in case of humoral immunity, it is implicated by the deposition of immunoglobulin and complement on nerve myelin, and also by passive experiments that include induction of these axonal blocks and demyelination by transferring serum and immunoglobulins from a patient of CIDP into experimental animals. On the other hand, the cellular autoimmune hypothesis is supported by the evidence that there is T cell activation and crossing of these activated T cells by the blood. These T cell cross the blood nerve barrier, and they cause nerve damage inside the blood nerve barrier by producing certain inflammatory mediators, chemokines, and various chemical mediators. Now, 25% of the patients with clinical features of CIDP, they are associated with MGUS. That is also known as monoclonal gammopathy of undetermined significance. The cases which are associated with monoclonal IgA or IgG kappa subtype, these monoclonal IgA and IgG kappa, these are the subtypes of monoclonal gammopathy. They usually respond better to treatment as favorably as cases without a monoclonal gammopathy. I will not go into the details of monoclonal gammopathy because it is the topic of another section. Now, the IgM monoclonal gammopathy and the antibodies that are directed against MAG, myelin-associated glycoprotein, they have a distinct polyneuropathy. Anti-MAG neuropathies are characterized by sensory findings such as sensory ataxia and tremors. In case of sensory ataxia, the motor coordination is intact, but the sensory component of coordination is disturbed or impaired, due to which there is loss of balance. These neuropathies have a protracted course, and they show a less satisfactory response to treatment. Now, the diagnosis is based on certain characteristics that are based on clinical acumen, cerebrospinal fluid examination and its findings that include acellular with an elevated protein levels and a CSF pleocytosis, and also on the electrophysiologic findings. Besides these tests, there are certain other tests such as a blood test or an MRI, which are helpful in order to differentiate the other causes of weakness. A CSF pleocytosis, as with GBS, should lead to the consideration of HIV, leukemia, lymphoma, or neurosarcoidosis instead of CIDP. Now, whenever there is damage of nerve sheath, it leads to decrease in the transmission of signal across the nerve fibers, due to which we see variable degrees of conduction slowing on electrophysiologic findings, on nerve conduction studies. Now, if we talk about temporal dispersion of combined muscle action potentials, let me give you an overview about this. The large nerves of the peripheral nervous system, they consist of two parts: an axon, that is the central wiring, which is the core of a nerve, and it is responsible for the signal transmission, and a myelin covering, that is fatty insulating covering of the axon, which protects it, and it is responsible for maintaining that transmission of signals across the axon via saltatory conductance. Whenever there is patchy demyelination, it also results in it also affects the conduction of signals across the neurons. Some of the signals will reach their intended target sooner, and some of them will reach later. Due to this discrepancy in the signal transmission, there will be a phenomena called as temporal dispersion, in which the signals are being transmitted to their intended targets, but the time to do so will be more spread out. Whenever there is conduction block on nerve conduction studies, it shows that there is an acquired demyelinating process that is going on. In more than 50% of the patients, there is evidence of axonal loss. And we also perform serum protein electrophoresis with immunofixation in order to find out if the CIDP is coexistent with monoclonal gammopathy of undetermined significance. In patients with presumptive CIDP, it is reliable to exclude other causes that include vasculitis, collagen vascular disease, chronic hepatitis, HIV infection, amyloidosis, diabetes mellitus, inflammatory bowel disease, and lymphoma. All these diseases can coexist with CIDP, or they can somehow cause the similar signs and symptoms of a polyneuropathy. Now, moving on to the treatment of CIDP. Treatment is initiated when the progression is rapid or the walking is compromised in a patient. If the disease is mild, an expectant approach should be taken, awaiting spontaneous remission. Studies have shown that high-dose intravenous immunoglobulins, plasma exchange, and glucocorticoids, these are all effective as compared to a placebo. The standard initial treatment is started with intravenous immunoglobulins with a dose of 2 grams per kg body weight given in divided doses over 2 to 5 days. 3 monthly courses are generally recommended in case of intravenous immunoglobulin. Now, if the patient responds to treatment, the infusion intervals can be gradually increased, or the dosage can be decreased to 1 gram per kg per month. Plasma exchange that is considered to be as effective as intravenous immunoglobulin, it should be initiated at 2 to 3 treatments per week for almost 6 weeks. But most of the cases require a periodic retreatment. Treatment with glucocorticoids have also been effective in case of CIDP, starting with a dose of 60 to 80 milligrams of prednisolone. It is given per oral daily for around 1 to 2 months, and then followed by a gradual dose reduction of 10 milligrams per month as tolerated by the patient. As much as the benefits of glucocorticoids, there are certain long-term adverse effects, which include bone demineralization, gastrointestinal bleeding, and Cushingoid changes. These can be problematic for the patients, and these need to be dealt on with. If the patients do not improve with the standard treatment options, such as the intravenous immunoglobulin, plasma exchange, or glucocorticoids, they can be treated or they can be given a trial of immunosuppressive agents such as azathioprine, methotrexate, cyclosporin, cyclophosphamide. These are all can be given either alone or as an adjunctive therapy. And in some cases, the anti-CD20 rituximab has also shown improvement. Now, in patients with a CIDP-like neuropathy who completely fail to respond to treatment, it is very, very important to evaluate for Poems syndrome. This syndrome is characterized by, it is abbreviated as polyneuropathy, organomegaly, endocrinopathy, monoclonal gammopathy, and skin changes. It is basically a chronic progressive demyelinating neuropathy, which is associated with plasma cell dyscrasias such as MGUS or multiple myeloma, and multi-organ disorder, and it does not respond to treatment. So it is very important in patients who fail to respond to treatment, always evaluate for Poems syndrome. This was all about chronic inflammatory demyelinating polyneuropathy. I hope you're excited to learn more about these immune-mediated neuropathies. Stay with us and keep watching Scaria.com.